Hello viewers, welcome to the latest episode of The Right People. I am Arihant Paudia, Senior Editor at Swarajya magazine. Today we have with us Dr Indu Bhushan, Chief Executive Officer of Ayushman Bharat and National Health Authority. Welcome sir.
Thank you.
When you launched the scheme, there must have been some parameters or some tests that you thought that if we can achieve those, we can call it a success. What were those parameters or tests?
See, these parameters are long term, medium term and short term. So the day we were launching the scheme, our parameter was that our IT system is going to hold up. We will be able to provide the services as we are planning. In the medium run, we hope to provide services to about 15,000 people every year and reach to all our 50 crore people, 10 crore families. And in the long term, of course, we want to reduce the cost out of pocket expenditure. We want to reduce the cost. We want to improve the services in public sector. We want to improve the services in the private sector. We want to improve the accessibility of services and affordability of services. So we are hoping that in 3 to 4 years time, if we are implementing this scheme well, we should be able to change the face of the health sector in the country, make the quality of services better, more affordable, and reduce the impoverishment, actually eliminate the impoverishment which is there because of the health expenditure.
So it's such a huge scheme. Even a small scheme cannot be implemented without overseeing everything, right? So there has to be some teething problems. So have you witnessed anything that you did not anticipate in the beginning?
You know, problems come every day. We cannot foresee every contingency, and therefore we have to make plans, or maybe we have to make corrections almost on daily basis. But there is nothing major. We have not found anything which was fundamentally wrong in our approach. As I mentioned, our design has stood the test of time, and IT system has proven to be very robust, and in general actually the scheme has been running very smoothly. You may have seen in the past there were many other programs here and outside which have seen major bottlenecks. For example, when Obamacare was launched, their website went down for a long time. Their call center could not cope with the load of the calls, but that has not happened here. We have been now servicing about 15,000 patients every day. We've been issuing 3 to 4 lakh cards every day, and in that sense, this scheme has not given us any surprise.
You talked about Obamacare for instance, but this scheme is not strictly speaking an insurance scheme in the manner that people are not paying the premiums. Second, because most of the states are not following a strict insurance model. They have trusts, so it's not strictly an insurance scheme, is it?
What we call it is an assurance scheme, that government is assuring the poorest 40% people of the country support for any health expenditure arising out of any serious illness. You know, there's a thin dividing line. Even if the persons or beneficiaries are not paying the premium, it could be an insurance scheme, because if the government is paying the premium in place of the beneficiary, it still is insurance scheme. For example, RSBY used to be an insurance scheme. Although people were not paying any premium themselves, their premium was being paid by the government. So in this case, you're right that some states have followed the insurance path. In some other states, government itself is acting like insurance company. Instead of payment being done by an insurance company, a society or trust is going to make the payment. So as far as the end effect is concerned, there is a risk pooling. There is a payment to the provider for providing services, and so for a beneficiary it is just the same. Back end, how the payment is done, who gets the payment, that is different.
Can we see in the future, for instance, that in any insurance scheme we see that most of the people are paying the premiums, and then there is a small subset of people who are getting benefited out of it. Currently only the poorest of the poor people who cannot pay are included in the scheme. So in the future, can we see that middle class, rich people are also included, and they start paying the premiums, and from that money we can finance some part of this scheme for the poor?
That's a very good question, and India is committed for universal health coverage. Our 2017 policy says that we will achieve national health policy, commits ourselves for universal health coverage. If you see it now, under PMJ, we are covering about 40% population. But beyond PMJ, many states have actually already expanded it for other people, and so they are covering about 20% more than us, so 60%. Through the top up, and then they on the top at the corporate sector, formal sector like CGHS, about 15% are covered there. So if you look at the total population, 75% is already covered through either PMJ or through other state schemes or private insurance. Now the question is about this remaining 25%, and you're right that for getting the maximum out of our system, and for ensuring the risk pool which covers everyone, we have to also include the remaining 25%. Now remaining 25%, it will be difficult to have a scheme, because we also don't want adverse selection, that out of those 25%, only those people who are likely to use services may join, and if they do join and remaining healthy population doesn't join, then you will find that the cost of a scheme and the premium to be paid will go up very high. So of course they should be included, but when we'll do it, how we'll do it, there are many open questions, and we'll have to wait for some more time.
So one of the problems with the Rashtriya Swasthya Bima Yojana (RSBY) was that the premiums across the states was starkly different, highly varying. And another problem was that premium was high, but now with so many crores of new people coming into the system, so have the premiums come down, or and the another question, of course, have the varying difference that was in the states before, has that question or has that problem been solved?
Okay, there are two questions that you're asking. One is that the premium were different across states, and that is to be expected, because the premium is based on the likely use of services, and likely use of services is function of the healthcare seeking behavior and the cost. And in different states, we already know that cost structures are different. Cost of services, say in Delhi, will be very different as compared to, say, in Bihar, and availability of services here is very different as compared to in Bihar. So obviously we would expect much higher premium in Delhi as compared to in Bihar, because the cost is low and also use of services is low in Bihar, right? So we will expect that, and that's exactly what we are seeing, that in some states we've got premium of more than 1,500, and in some states we've got about 400. So there's a variance across states. And we should not be worried about that, because that is going to happen. Now, question that whether the premiums are going down because we are increasing the size, but you also have to see that RSBY was covering only 30,000, and we are covering 5 lakh. So we've increased the coverage. At the same time, RSBY was covering only secondary illnesses. We are covering secondary and tertiary both. So in that sense, our coverage has increased in terms of the amount and about the benefit package. So because of that, of course, we should expect higher premium, but at the same time, like you mentioned, since we have increased the numbers, there will be some downward pressure. But lucky thing is that we have, while we have seen some increase in the premium, but increase has not been that dramatic.
Some people are saying, some economists or analysts have predicted that the total cost will be upwards of 50,000 crores. The government's estimate is, I think, 10,000 crore. When it has not stabilized yet, when it stabilizes over a period of maybe 2-3 years, what do you think will be the cost estimate of this scheme?
It's very difficult to see the future. But my own personal guess is, and it's not based on, it's not official number. Right now, you're right. What we're seeing is that per capita, per hospitalization cost is about 12 to 13,000 rupees, and that's what we see so far in the first 6 months. And if we believe that there may be 1 crore cases which are coming, so our cost will be about 12,000 to 13,000 crores. Over time, if the number of hospitalizations say increase to 1.5 crores and maybe the cost increases by 10% to about 15,000, then we'll be looking at something close to between 20,000 to 25,000 crores.
So that's divided between center and states in
60 and 40. But if you see this cost in relation to GDP, 0.5% of GDP is 75,000 crores. And so 25,000 crore is about 0.15% of GDP. And we are spending too little right now on health. And if we increase our healthcare budget, which is about 1.2% of GDP, to about 1.5% of GDP, I'm not even saying 2.5, which is our goal, a goal for under the health policy, we should have more than enough resources to support PMJ, but also support other major initiatives which are right now being taken in the health sector.
One of the criticisms of the scheme is that it focuses on secondary and tertiary care, and kind of ignores primary and preventive health care. But we know that one of the aspect of the scheme is setting up 1.5 lakh centers that will cater to exactly preventive and primary health care. So can you tell us more about that aspect? Because in the media, in the news, we often hear about people getting treated for secondary and tertiary care, but what about primary and preventive? That is also an important part of the scheme.
You're absolutely right. And we, for last 70 years, the major emphasis has been on supply of services through the government machinery and primary health care. And under this scheme, Ayushman Bharat, as you mentioned, there is a strong emphasis on primary health care through creation of 1.5 lakh health and wellness centers. And work on that actually has been quite impressive so far. We have 16,000 health and wellness centers which are operational, and our colleagues in Ministry of Health have been working very hard on this leg. Our authority, National Health Authority, does not work on that leg. We focus on the second part, PMJ, and success of our scheme, the Pradhan Mantri Jan Arogya Yojana, is critically dependent on success of the other leg, because unless we have a strong primary healthcare system which can prevent many of the illnesses, which can provide source for referral, and also help in terms of providing support after the patients are discharged from hospitals, our scheme will not be successful.
It becomes more critical because the people who are covered, the 50 crore people, are poorest of poor.
That's correct.
Who need primary and preventive health care the most.
Absolutely, absolutely. So I'm happy to say that the other this health and wellness center leg of Ayushman Bharat has been working very well.
Private sector in this scheme is going to play a huge part, and you said that one of the key parameters that will define the success of the scheme is how many private hospitals come and join the scheme. So what percentage of private hospitals in the country have enrolled into Ayushman Bharat?
Well, we don't have the correct picture of how many hospitals we have, because the definition of hospitals in terms of from clinic to big hospitals vary. But so far, 15,000 hospitals, close to 15,000 hospitals, total hospital have impaneled with us, and out of those, more than 50% are private hospitals.
More than 50.
So about 8,000 hospitals are private hospitals, and we have seen interest from all big hospitals in terms of being associated with Ayushman Bharat. Most recently, Sir Gangaram Hospital in Delhi, they joined Ayushman Bharat, and many other good hospitals are joining.
Chains?
Medanta has joined, Narayana Hridayalaya has been supporting us, in they're part of Ayushman Bharat. So, and others will also join slowly, because it's been only 6 months, and some hospitals have been waiting and watching how the performance is. But in the medium run, I don't see why these hospitals are not going to joining it, because we are going to be providing them a huge business.
Okay, but whatever we have heard in the media is that from their perspective, they think that the rates of treatments are very low, and I think the rates are 20% of what they were in RSBY, 20% lower. So that's like 2008-9 level of rates. So even if we factor in the inflation of the last 10 years, it's simply not sustainable. So that is their view, that why we should join when we are not even getting the,
Well, I know that this has been a topic of discussion, but we believe that our rates are not that low. We've not taken RSBY rates. There was a committee made, they worked for 2 years, and which decided these rates. But there may have been some omissions, and we are looking at that. But in general, I would say that rates are quite fair, especially in the view of the fact that we are going to be providing large volume. So this scheme is going to be moving the whole system from high margin and low volume to low margin and high volume. And here, of course, rates are very important, and we also don't want to increase the cost of healthcare in the country. So we will keep a cap on the cost, but wherever we find that there is legitimate reasons for reviewing the cost, we are open to doing that.
Okay, but however the rates were set, was there a expert committee of taking stakeholders from views of stakeholders from every insurance, from healthcare industry, from professionals, or was it exclusive of bureaucrats? So how were the setup?
Well, it was mostly technical people, and it was chaired by DGHS, and it involved a lot of specialists from AIMS and other places, and this was reviewed by another technical group headed by Dr. Vinod Paul, member Niti Aayog. So these numbers did not come out of any file or from any bureaucrats thinking, imagination. So there was a technical exercise done. But like I was saying, that technical people are also human beings, and they may have committed mistake. But also you will see that rates are not same across the country and across all hospitals. Rates in a corporate hospital will be very different as compared to government hospital, or as compared to even not-for-profit hospital. Similarly, as I mentioned, rates in Delhi will be very different as compared to, say, rate in Gorakhpur. So we'll have to see how we define rates and provide flexibility so that those rates can be applied differentially in different places, keeping in view the cost factors.
People in Gorakhpur will, if a hospital sets up there, a chain sets up a hospital unit there, then these rates may be more suitable for them there. Maybe not in Delhi, but there, because infrastructure and every cost in Gorakhpur would be less than the investment in Delhi. So there should have been some movement, some commitment from the private chains, from the private entrepreneurs to set up these chains of hospitals. Has there been any movement towards that?
There is a very intense discussion on that. I have met with many people who have told me that footfalls in their hospitals, which are in tier 2, tier 3 city, have increased. There is no doubt about that. Already we see that trend. We also have found people who are thinking of expanding their services in tier 2, tier 3 cities. But as you know that these things take time. Even the approvals for setting up a hospital, let alone real construction, will take some time. But the thinking has started, discussion has started, and many people are also looking at how this scheme stabilizes, because it's been only 6 months. And so far, of course, we've been doing well, but they also want to see what happens after the election, or how a scheme does later in the year. So because if business people have to take a business call in terms of expanding their hospital network, they will have to be sure about the future of the scheme.
But sir, in terms of setting up new hospitals, it's not just the hard infrastructure that is easy to set up, but there is a soft infrastructure in terms of hospitals, nurses, the human capital. So we have created a huge supply of patients, access, we have given them access, but where are the doctors, right, to treat them?
Very good question.
And when you talked about, for example, it takes time to set up hospitals, right?
It takes time to train a doctor.
Train a doctor, yeah.
7 or 8 years.
So how do we, enable the ease of opening, running a hospital, establishing a hospital?
See,
and,
you have to see 2 or 3 things. One, that we are going to be improving efficiency in the sector. So right now, there is a capacity, excess capacity in private sector. So this scheme is going to help private sector use that excess capacity. This scheme is also going to improve the quality and efficiency in public sector, so that they can treat more patients. At the same time, you have to also look at the distribution, because of course we have a problem with the number of doctors, but also there is a problem of distribution. Most of the doctors are located in big cities. So when there is a demand in tier 2, tier 3 cities, there will be some redistribution, and that will also lead to improved efficiency in the sector. So that's going to happen in the short run. In the medium run, we are hoping that machine learning and AI and telemedicine is going to help us improve the capacity in the sector, where doctors who don't want to, say, move from Delhi, but can also use their skills through telemedicine and provide those services in the.
Maybe we can have some operators.
That's correct.
In
a small town, and from here, specialized doctors can guide them and provide the diagnosis or treatment plans.
Yeah, but still we will need a lot of medical colleges and all that regulation.
That is going on in the on the side. As you may know that government has this. We are planning to establish medical colleges in every district. There's so many new aims coming up. So I think increasing supply of doctors, that effort is going on, but it might take some time. But in the meantime, we are going to use the excess capacity and improvement in efficiency to provide these services.
This is the IT backbone of the Ayushman Bharat scheme is National Health Stack, and which is generating a huge wealth of data. For the last 6 months, you already have, I think, a lot of data with you. So can you tell us some productive uses that the data has been put to?
Okay, you're right that we already have a huge amount of several terabytes of data, and we will in the future accumulate even more. And right now we are using the data to monitor the scheme and seeing what the scheme is doing in terms of access to services, what kind of services are being used, who it is serving, and so monitoring the scheme through this data has been quite useful. Also, this data is being used to look at fraud and abuse, and we are using the data to see if some of the transaction may be fraudulent, and once we have those triggers, we go and investigate. But in the future, we also want to use this data to see if it is telling us something about some policy implications. If certain type of disease pattern is emerging in certain type of areas, in certain type of demographics, and is it because of say issues related to water or pollution or anything else that may be going on. And with that, we can have policies which may be related to fair price shops, or kind of food that we provide, kind of education that is needed, or kind of work we can work on, say, drinking water.
That's
aspects.
going to be a huge input to policy making in the
public
future.
policy, yes. At some point we'll have to do that, but the couple of issues. One is that medical data is extremely sensitive, and it has a lot of privacy concerns. And yes, so we'll be, of course, even for our purpose, we have to anonymize it. We have do encryption of data so that it can't be misused. But in future, we are going to make much of this data public, because unless we open it up to public for doing more research, probably our own capacity here may be limited, but we want to unleash the capacity in general in other research organizations and people to, but also to, we have to be, firstly, one concern we had is about the privacy. Other concern is that whether it can be misused commercially, and we want to avoid that as well.
So you talked about fraud if there is a case where a hospital is found to be indulging in that kind of activity, what is the procedure for suspension or any disciplinary action, anything?
Yeah, we have separate different levels of sanctions for any small abuse, or not abuse, a small mistake. We just give the warning. If abuse is a little bit more grave, we can fine them, we can de-impanel them, and if there is outright fraud, we can also file an FIR and start a criminal case against the hospital.
Okay. Recently, Rahul Gandhi, and P. Chidambaram and Rajiv Gowda, Congress people, they, recently launched kind of a scheme, outlined their initiative, saying that we want to provide you health assurance, not health insurance, basically taking a swipe at Ayushman Bharat. And they said that we want to have a system where anybody can walk into a hospital and get treated, and they said that we want to include outpatient OPD expenses also, which are not covered in Ayushman Bharat. So what do you think about that aspect, that scheme, that
when
plan?
we have to go through universal health coverage, we have to include OPD at some point. And of course, this scheme does not include OPD. It's only for inpatient, and in that too for serious illness, right? And any scheme that you have for universal health coverage promoted by any political party, they will have to have provision for providing services for secondary and tertiary care for poor people. Of course, for rich people, they can probably afford themselves, but the poor people, they can't afford hospital care. Right now, 6 crore people fall into poverty because of expenditure on health. So these people have to be covered in any scheme which you bring in. Now, if the idea is that all these people can be covered through public sector, I have my own doubts, because right now 70% of the health care is provided by private sector. Our public sector is not equipped fully to provide services to these people, and the public sector also does not have full incentive to provide services. So our scheme uses both public sector and the power of private sector to support these 40% poorest people. And I think in my view this is a good model. There may be other models out there, but I have not seen any better model. So I have a feeling that while supporting OPD and strengthening public sector is a good approach, but we cannot afford to have a scheme like ours.
You have received a lot of flack actually for people are saying that you are incentivizing the private sector to expand at the cost of public hospitals. So can you address that criticism?
Well, private sector is already present, and private sector is providing services to for about 70% of healthcare. And right now that private sector, and especially quality private sector, is out of the reach for the poor. And this scheme is making this affordable for those poor people and opening the doors of these quality private sector hospitals for the poor people. And if we have to do that, of course, we have to provide resources. I don't see anything wrong in that. At the same time, we are providing resources for the public sector. Public sector, of course, is getting money through their line budget, but in addition, they are getting money from PMJ for providing services to these people. So in that sense, we are actually supporting both public and private sector.
That's true actually, and public hospitals are also getting the money routed through Ayushman Bharat, and that's kind of an investment. Sir, we wish you huge success in this initiative because it's very important for the country. Thank you for joining us.
Thank you for your time.